So we have... All right. Good afternoon, everyone. Welcome to this side event on low carbon and climate resilient healthcare. It is co-organized by the University of Heidelberg and Sciences Po, so University of Heidelberg in Germany and Sciences Po in Paris, in France. And I'm Charlotte Halpern. I'm a member of one of the organizers at Sciences Po. I'm a researcher there, a political scientist, and...
Yes, I'm Max Jungmann. I am the executive manager of the Heidelberg Center for the Environment at Heidelberg University, and also political scientist.
And so in this session, what we want to work on and explore together with our panelists is how the World Health Organization introduced some frameworks a few years ago for climate resilient and low carbon healthcare. And we want to take a holistic view within this panel in order to look at how different actors in Germany, in France, in Switzerland, in Chad, in the Maldives, we've been looking at different contexts, contribute through their research and their practice to making this framework come true and also to deliver on this. So we have a number of speakers this afternoon, and we are going to go through that. Some of them are going to be online, some of them are in the room. We're going to start with the global perspective, which is going to be provided by Max Jungmann on my left. Then we'll have a presentation by Patricia Schwerdtle, who will be speaking about building climate change resilience in healthcare facilities in fragile settings. Then we will go to Heidelberg University Hospital with Heiner Sauerborn on my right. And Noemi Bender, who will be online talking about sustainability and climate protection at Heidelberg Hospital. And we will then continue with a comparable carbon footprinting tool for German hospitals. And this perspective will be given by Alina Herrmann online and her colleagues Claudia Kittmann and Bernd Franke.
Exactly. And then we will continue with our colleagues from Paris. And from Switzerland first a roadmap for conducting the ecological transition of the Swiss healthcare system by Nicolas Senn, and then decarbonizing the healthcare system, key challenges for public policies in France by Annelies, who's sitting over there, Annelies Depoux, and Charlotte Halpern, and contributions by Matthias Brunn.
So as you can see, we really decided to go beyond the principles, the objectives, the nice, roadmaps for the future, and want to look at what actors are actually doing on the ground and trying to see how with our own research and practice, how we can bring together some tools, some guidelines, and some practical measures that could be implemented on the ground. And we want to look at this also in a critical way. So over to you, Max, for the first presentation.
Yes, thank you very much. And before we zoom into the different policy areas, I will start with a global perspective and just to give you an overview of what is going on globally. Also, in the end, we will have a discussion after all of the presentations. I'll start with a global perspective. First of all, we're seeing that climate change is no longer just a challenge in the future as it has been perceived for quite a long time, but it is actually affecting our health right now. This is a picture of New York City from this year. I believe it was in June. And this also shows the complexity of sustainability challenges, because what we saw here was that people in New York City had to wear a mask after we hoped that the COVID pandemic was over, or we wouldn't need to use masks outdoors. Again, people had to wear a mask again to go into Central Park and other parks in New York, parks where we usually go to breathe fresh air in a city like New York that is very hectic. And the reason why they had to wear a mask was not a cause directly in New York, but it was the wildfires in northern Canada. And that shows the complexity of sustainability challenges. They're they're global challenges, so sometimes you feel the effects of what is going on in different places in the world. They're long-term challenges with short-term implications, and they already affect our health. And this is just one of the examples from the global north. We'll be hearing examples of the global south later as well, and we also need to understand the climate justice dimension behind this, as we will discuss, especially when we're talking about resilience. So we see that climate change is affecting us right now, and the health sector plays a crucial role in this. First, because the health sector is affected. We see more health risks associated with climate change, but also the health sector directly contributes to climate change with its emissions that it's causing. And what we're also seeing at the same time is that awareness for climate change and health is increasing. Here we see a picture of the COP in Glasgow 2 years ago, where for the first time health was mentioned in an outcome document in the Glasgow Climate Pact. And last year in Sharm el-Sheikh we had the WHO pavilion, and we saw more and more awareness for health, that the climate crisis is a health crisis. And we see that advocacy is starting to focus more on health, to also show that climate change is not just an abstract challenge, but it directly influences us and our health, not only in the future, but right now. And we're seeing that this is also integrated into documents. First, health was mentioned, now it's playing a more and more important role, and here we're already seeing that it contributes to, there's more funding available, the 777 million that were adopted a couple of days ago, and there's more awareness for the need to increase funding to deal with loss and damage in terms of climate change and health, but also to improve adaptation and resilience building, but also to make sure that the health sector plays its role in terms of mitigation. And the urgency becomes even clearer when we look beyond climate change. Recently, a few weeks ago, the update to the planetary boundaries was published by the Stockholm Resilience Center and the Potsdam Institute for Climate Research. And we see that compared to 2009, where 3 boundaries were crossed, in 2015, where 4 boundaries were crossed, in 2023, already 6 planetary boundaries are crossed. So now we are in areas that are no longer safe. And we're seeing that the way that we deal with our resources is absolutely not sustainable. And here you can see how health is connected to this as well. For example, when we look at biochemical flows, because the way we deal, for example, with chemicals like phosphate or nitrate in agriculture is directly connected to our food systems, and sustainability is a broader issue. But we also see that in terms of climate change, we're moving very quickly, and I don't need to tell you that the 1.5 degrees Celsius goal is getting much harder to reach. And the health sector plays a very important role in this regard, not only because it's affected, but also it contributes to the challenge, because it contributes 4 to 5% of global GHG emissions globally. In some countries this differs, of course, but in Germany, for example, this makes 5.2% of the greenhouse gas emissions in Germany, which is higher than, for example, the emissions in the aviation sector. So health is the health system is an important actor when it comes to mitigation as well. Hospitals are crucial here because they make up 1/3 of all emissions in the health sector. And there are also some studies that show that we could maintain the same performance, the same functions of the health sector while reducing 50% of the environmental damage, the environmental footprint that it creates. When we look into later how the health sector can contribute to sustainable development, there are different levers, as we will hear later on. There are the traditional ones that we often look at, like buildings, transport, energy efficiency, renewable energy. But one of the biggest levers is actually supply chains and the power that you have in procurement in hospitals, because more than 70% of the emissions of a hospital are typically Scope 3 emissions. So with that, you can have a big impact on reducing your emissions, and this can happen much quicker than long-term investments in infrastructure, for example, when it comes to the building efficiency or investments in renewable energy. If you have a good overview of your supply chain, your suppliers, and you know what would be more sustainable options to procure, that is a big lever that you can use, and we will hear later on how important Scope 3 emissions are. Of course, hospitals also have the power to use the influence that they have to raise awareness via their patients, via healthcare workers, and so on. So they play an important role. But at the same time, pressure on the health sector is increasing. In Europe, we see that regulation is increasing, for example, through the EU Corporate Sustainability Reporting Directive, CSRD, which requires many hospitals to publish a sustainability report according to the European Sustainability Reporting Standards. We also see that the EU taxonomy is influencing how you get access to capital, to financial capital. We see that the EU Corporate Sustainability Due Diligence Directive, or in Germany, the European Supply Chain Act, is putting pressure on procurement to have a better understanding of the risks along your supply chain and to see how you can use that to push for sustainable development. At the same time, we see that at venues like here, engagement is increasing. There is more and more pressure by NGOs. We see NGOs like Healthcare Without Harm, for example, or MSF organizing themselves really well here and using these venues to put the topic on the agenda. We see that celebrities, for example, in Germany, Eckhard von Hirschhausen, a very famous person, use their awareness to put pressure on politicians to see that the climate crisis is a health crisis. And we see that healthcare workers and talents are demanding their institutions to do more on climate action as well. At the same time, this becomes a strategic issue for CEOs, for executives, for people in procurement, because access to financial capital is limited if you are completely unsustainable. And this is where the intersection between, for example, the taxonomy and the finances in a hospital come to play. We see interactions throughout supply chains that you can have an influence on your suppliers if you motivate them to have more sustainable products at offer. We see that shareholders are requesting more, and of course patients are asking to do more. This is the mitigation part, or sustainable development within health sector institutions, and the other really important part is described here by the WHO, where we see how climate change already influences our health today, and this will exacerbate in the future. It will increase to vulnerability and connect with already existing vulnerability factors like demographic factors or geographic factors, and there's a large number of new climate-sensitive health risks, for example, in terms of infectious diseases, heat-related health risks, floods, extreme weather events, mental health risks. So we see that in terms of the impact of climate change in health, there's much more knowledge nowadays on how it influences our health, and that it is absolutely pivotal that we adapt, and that we adapt sustainably. And this connects to resilience building and our next presentation by Trish.
Thank you, Max. Thanks a lot. So the decarbonisation of health systems in high-income countries is really important. As Max said, it's 5% of emissions. But the other side of this is building resilience in developing countries. So we shouldn't forget that 1 billion people are served by health care facilities that don't have access to reliable energy. And 1 in 4 healthcare facilities don't have access to water. So you can just imagine what it's like to deliver a baby or to do any kind of medical procedure without being able to wash your hands or without having any light. And so today I'm going to introduce a practical implementation project that we're doing in Chad with the Climate Action Accelerator. I'll talk about what a climate resilient health system facility looks like, introduce the context of Chad, outline briefly the vulnerability, capacity and adaptation assessment that we did in Chad, and introduce the 35 solutions. So maybe as we're going through it, you can think what sort of solutions does this context need, and see if you're surprised or unsurprised at the end. So what is a climate change resilient health system? It's a health system in a nutshell that can anticipate, prepare for, respond and recover from climate-related health risks. So that's the WHO definition. It's pretty much a health system that doesn't collapse when there's extreme weather events, but let's not forget it's not just about those sudden onset climate hazards, but the slow onset ones as well. And as Max said, it's about changing patterns of infectious diseases. I did a study recently where a health team pretty much summarised the impact of climate change on health facilities as more patients, a stressed workforce and a damaged infrastructure and compromised supply chain, which makes it really difficult to look after patients. So if you have a look at this WHO image, it really puts that definition into a bit more context. On one side, you've got health system capacity, so you can have low, below average, acceptable, etc. And on the other side, you've got health system resilience. And then in the middle, you've got stresses and shocks by climate change, whether it be drought, flood. So what can happen is you can have a performance drop and the health system can collapse. It can recover, but worse than before, or it can recover to its normal state, or it can actually transform. And resilient systems, we're aiming for them to be able to deliver services, but also to learn from that shock experience. And we all experienced, we'll saw in the world what can happen when healthcare systems collapse through the COVID pandemic. So climate resilient health systems aren't just resilient against climate change, but also other shocks and stresses, whether they're pandemics or conflict. So just introducing a context in Guri Hospital in Chad. The challenge here is to transform a general hospital into a creche, which is a climate resilient and environmentally sustainable hospital. This context is located in Western Chad, and the health facility serves 160,000 people, but there are only 80 beds. It's close to the Nigerian border, so there's conflict problems which complicates delivering healthcare, including incursions by Boko Haram and population displacement. It's also in the Sahelian region, so there's lots of food and nutrition insecurity. And this hospital partners with NGOs called Alert Santé, Alima, and the Climate Action Accelerator for this project. So you might be aware of a VCA, or a Vulnerability, Capacity and Adaptation Assessment. This can be done at the national level, which is probably what you're most familiar with, and that's how you develop a national adaptation plan. So a plan to adapt the country in a nutshell. Some of these have some health components in them, or you might have a dedicated health national adaptation plan, otherwise known as a HNAP. But you can also do, according to the WHO, a VCA of the health system in a country. And what we decided to do was a VCA at the facility level. So the rationale behind this is if you do bottom up in combination with top down, you can accelerate climate action. So it pretty much involves 6 steps. First, we established a multidisciplinary operational team. They're all standing around the table here. So it includes the NGO representatives, MOH representatives, Ministers of Health, and the health professionals and the health management team from the actual hospital. Then we undertook a mixed methods assessment, which includes a desk review. So we did a literature search to see what are the key hazards that this particular hospital in this particular part of Chad is going to face today and in the future. And then we did focus groups, and we brought this team through a number of scenarios about what is likely to happen to this hospital under the current and future projections of climate change, and what they think the specific vulnerabilities will be in that hospital. And then we did a facility audit to capture other data that wasn't captured in that qualitative process. This produced a risk solutions matrix, and from that we selected priority actions for climate resilience. The next challenge will be financing and implementing the interventions, and also evaluating and publishing it is really important, because looking at this literature, there's a whole lot of evidence on the impacts of climate change, and there's much less on the solutions. Here are the 35 climate solutions under 6 domains. I'll just go through them briefly. The first domain is infrastructure, technology and products. The main need was to strengthen oxygen concentrators because they were having high rates of mortality from malaria and malnutrition because of a lack of access to oxygen. Cool roofs, you can see that guy painting the roof with a highly reflective paint. The clinical areas can reach up to 50 degrees, which is really bad for the mortality rate of malnourished children. Developing energy infrastructure, renewable energy infrastructure that also can meet the peak needs. That little red house there is a common waste area that is planned to be built. And there are kind of hard and soft interventions in this solution matrix. Some of them are about infrastructure, but they're not all about infrastructure. There was also a need to develop a disaster team and some emergency protocols that weren't in place before. And also to strengthen the blood bank, because that was a key area of vulnerability in terms of the projections of malaria and malnutrition in the future. So just to summarise, I suppose, were you surprised by those solutions in terms of them making the hospital more climate resilient? Some people might be, because there's a lot of donors looking for kind of niche projects about climate-sensitive diseases. But at the end of the day, a lot of these solutions are actually well known to us. They're about universal healthcare, health system strengthening, and disaster risk reduction. I'll leave it there. Thank you very much.
Thank you very much, Trish. Now we're handing it over to Rainer Sauerborn and Noemi Bender.
Can you give me them?
Yes, of course.
Yes,
And
hello.
Noemi is online.
Yes, Noemi is online. Well, hello, I'm Rainer Sauerborn. I work at the University Hospital, and I am very happy to present, to introduce two presentations. One is by the, you see this here, by the director, the director of the hospital, Professor Autenrieth, the last author, and that is already a message. He is in charge, and he wants us to do this, and what we are doing we'll be telling you, but this is probably the most important slide, which shows the commitment of the director of the hospital. And Noemi Bender, the first author who's going to present, take over from me, is a staff position. She's a doctor of health care, and she is a staff position responding and reporting to the director directly on climate change and sustainability. Also, this is remarkable, and I'm in the middle. Okay. This shows the target, the context in which we operate. We are, you see the map of Germany in the bottom, in the top right, and we are in the bottom left, a very industrialized state. Daimler-Benz is there, Porsche is there, and Bosch, and many others. So this state is governed by a green state government, and this is the reduction path that all public enterprises have to follow, so our hospital. And you see the 1 million tons of CO2 equivalent, and the path down from 2020 to 2030, minus 65%, which is pretty ambitious, and to climate neutrality by 2040. And our director wants the hospital to follow suit. So far, no other hospital in Germany has such an agenda and follows up on such an agenda. So we are pretty proud to lead the pack. The emissions in the German health sector, as Max already said, is not only the only problem, but there's also the vulnerability to extreme events like flooding, and this is in Germany as much as in the world in general. And you know that it's also mentioned that it is highly publicized that the air transport is 3.2%. Everybody shows, all the media show starting a plane, but the health sector has almost double. And if you ask a doctor or a nurse, they will say, oh, we are saving patients. Do you want us to stop doing this? Of course, that's not the point. You can do the same quality of care with less emissions. And that is what this talk is all about. And of course, the mantra of all health workers is, the first thing is do no harm, and that is expanded now to the climate. Not only do no harm to patients, but do no harm while you take care of patients, do no harm to the climate. And with this, I hand over to Noemi, who will lead us to what the hospital does, and then in the second presentation, you will see some measurement tools, because it's not easy to measure the carbon footprint of a hospital. Noemi, over to you.
Thank you, Rainer. Yes, the question is, sorry, I hear myself double. Okay, there's an echo. I think it's gone. Yes, perfect. Thank you. Exactly. Thank you, Rainer, for introducing this. The question is, how do we get back to doing no harm? And before I answer that question, I will quickly introduce the University Hospital in Heidelberg. Can you see my slides at the moment?
When you would need me to change them.
Thank you. Okay, I'll say next then. Yeah, so we are a maximum care hospital with 2,000 beds and over 1 million outpatient cases per year. We have over 11,000 employees, including nearly 2,000 professors and doctors and over 3,000 scientists. So as a university hospital, we combine healthcare, research, and training. And you see, we are a very large and complex university hospital. And with regards to the climate crisis, as everyone else, we face the huge challenge to adapt and at the same time mitigate, so minimize our emissions. Next, please. And next, thank you, yes. So since this affects every part of the university hospital, sustainability is an overall task and not so for the entire organization and not just an isolated project, which means that we have to look at it also from an administrative or governance point of view. Sustainability has to be implemented in the organization strategy. At the University Hospital in Heidelberg, we are in the process of establishing an eco-management system, and to carry this strategy into every part of the organization, we plan to appoint green champions, which means they are mediators who on the one hand spread information and also support the implementation of measures. Next, please. Implementing these measures is the main focus of our activities. I will present 3 examples in the coming slides. Next. The final focus of our activities is raising awareness among the personnel. We organize information campaigns, target group specific information events, and workshops. Also, we inform the employees about our activities and we encourage them to join in. But let's get to some of the examples I mentioned in the next slide. Yes, one of the first measures we took at the University Hospital in Heidelberg is reducing emissions from anesthetic gases. You may have already heard that anesthetic gases have a significant impact on the climate. They cause a lot more warming than CO2 when they are released into the atmosphere. The gas with the highest global warming potential is desflurane. You see that with the huge graph there. In 2020, the Department of Anesthesia and our pharmacy decided to use other gases instead of desflurane and to reduce the flow rates during anesthesia. And this way, between 2019 and 2022, around 1,600 tons of greenhouse gas emissions measured in CO2 equivalents were avoided. Next, please. This is a huge success. Of course, when you look at it in relation to our total annual emissions, this amounts to 0.73%. So yes, this is a huge success, but it also shows that we urgently need projects like this in all medical disciplines, from general medicine to radiology and to dentistry, but also in the administrative parts. So therefore, I come to the next example, which is mobility in the next slide. Here, the Heidelberg University Hospital Board has decided on a variety of measures to reduce emissions from mobility. For example, through the promotion of cycling and public transport. Here, they use subsidies for public transport for the employees, also parking fees to make using the car less attractive, and by installing safe and secure cycle parking facilities. Also, flying for work is discouraged, but if it is unavoidable, the emissions will be offset. Also, people can work from home to avoid the commute emissions altogether. Of course, only in the areas where people can work from home, so mainly in the administrative part. The third example in the next slide is from our energy department. They will install PV, so photovoltaic systems, on the hospital roofs, starting with the Center for Internal Medicine. The pharmacy and central laboratory will follow, and then in 2025, our supply center, the parking garages, and everything will be covered in photovoltaics. This, of course, saves energy costs and reduces our greenhouse gas emissions. At the same time, they are also building charging stations for electric cars, and they are planning to build the infrastructure for renewable heating and cooling. The last example on the next slide is that we need to provide the hospital staff with the tools and knowledge to enable them to work sustainably. For the medical and administrative staff, we offer a textbook that conveys knowledge and strategies for clinical care and medical education in times of climate change. And in the project Plan Med 2.0, can you click one more? In this project, the lecturers of the medical faculty integrate planetary health content into the existing curriculum of the Heidelberg Medical School. Next slide, please. All these activities are coordinated by the Office for Sustainability and Climate Protection. So our role is to promote ecologically sustainable transformation of the university hospital. We represent the organization internally and externally on sustainability issues, and we report directly to the hospital board of directors. This QR code leads to our website, which is unfortunately only available in German at the moment, but feel free to drop by and see what we're doing, because these were only a couple of examples. And with that, next slide, please. I thank you for your attention.
Thank you very much, Naomi. We could hear you very well. Thanks a lot. Presentation. I think we continue with another case.
Alina.
From Heidelberg, with you, Rainer, and Alina, who is also online.
Alina, over to you.
My name is Alina Herrmann. I am a medical doctor by training. And I also hear an echo. I think now it's better. Thanks. I'm leading the project CLIOL, which works on climate change mitigation in hospitals through optimization of supply chain. And one main issue we have been working on is a carbon footprint calculator for hospitals, which is, of course, supposed to be a tool to reduce emissions in German hospitals. And I want to report a bit about challenges and opportunities. And this presentation was prepared together with Bernd Franke, who is a researcher at the IFOI Institute involved or leading the development of that calculation tool, and Claudia Quidman, who is the scientific coordinator in that project, and Rainer had the original idea for that project. Next slide. So here you can see just a German screenshot. Oh, I see that the slides have been mixed up a bit, but that is the final product of our project. So a carbon calculator for hospitals in Germany. And we had the opportunity to work together with another research project and an NGO, which is the German Climate Change and Health Alliance, who has now built a platform called CLIMEC, which is supposed to network German healthcare facilities in order to become more climate resilient and sustainable. And they now host our carbon calculator, on which I will detail a bit more in the following. Next slide. So the methodology of our calculator is hybrid. That means that we use top-down balances and bottom-up balances. Just in a nutshell, for the top-down balances, you actually use economic data to derive the emission factor per euro. So in our calculator, for example, we calculated emissions of pharmaceuticals by an emission factor which was 296 tons of CO2 equivalents per million euro, which was derived from economic input and output models. But we also have bottom-up emission factors, for example, the one from electricity, and that is based on actual consumption data. Next slide. So here you can see the final balance of our university hospital based on this calculator. And if some of you are familiar with the greenhouse gas protocol, you might see those or know those scopes, scope 1, 2, and 3. Basically, scope 1 means these are emissions that are actually emitted at the in the healthcare facility, such as the medical gases. The scope 2 emissions are emissions of fossil fuels burned outside of the facility area, but actually bought in form of electricity or district heating. And then we have this huge part of the scope 3 emissions, which are all the supply chains before and after the healthcare services which are provided at the healthcare facility. And here you can see that there is a huge share of medical products, which you can, this big part here, and pharmaceuticals, but we also considered gray emissions, so the actual building emissions from building, hospital buildings, and also transport from employees and patients. So overall, in 2019, we had 230,000 tons of CO2 from the University Hospital of Heidelberg, and that was about 17 tons of CO2 equivalent per employee and year. Next slide. So how does that calculator work now? We are a research project, but of course we want hospitals to be able to do that calculation without having a whole research team behind. That is why we actually have an online tool where the data can be entered that is needed to do the calculations, and a handbook which guides the hospitals through the data acquisition. And then we have an Excel sheet which is also supporting with some specific calculation. So already the calculator was launched in the summer. We know that at least 20 hospitals have already used the calculator. We do not centrally collect the data due to data protection reasons, so we cannot say for sure. But we do also know that on the CLIMAC platform, there are already more than 160 hospitals and healthcare facilities who are part of that network. And so we do hope that more hospitals and healthcare facilities in Germany will use that tool. Next slide. Still, we do know that the carbon footprint calculator is not the silver bullet for sustainability in healthcare facilities, because there are benefits, but there are also challenges. So basically, the benefits of such a carbon footprint calculation are that it creates momentum for action, because stakeholders are actually confronted with the CO2 emissions and also the areas where they are created. So it allows to identify emission hotspots. And it helps to specify actual planning of mitigation measures if you know where CO2 emissions occur. We also hope that, especially in the future, it will allow comparison between hospitals, because ideally that calculator will be developed into some kind of benchmarking tool where you can actually compare emissions from similar hospitals and also compare emissions over time, so that you can actually monitor emissions of healthcare facilities and actually see if there is a reduction. We also think that showing the emissions and giving numbers to them can create pressure for the suppliers, because Max has been saying in his introductory course that it is maybe a quicker way of reducing emissions in the supply chain than maybe building energies, although our practical experience is that it is not so easy, because the supply chains don't offer sustainable products in many areas. So, and there we also have the challenges. So for the methodology challenges, it is not so easy to actually set system boundaries, and top-down emission factors are also not routinely updated, which kind of makes the timely comparison, or the comparison over time, a bit harder. Furthermore, the bottom-up emission factors, which are more useful for the actual monitoring of reduction, are not available for a lot of items. And one other challenge is that it can be difficult for hospital to actually set aside the personnel to do the carbon calculations and to regularly update it. So there we also think these reporting directives that are set up may be helpful. So if a carbon footprinting would be part of these kind of directives and hospitals would be obliged to do them, that would be helpful to actually for the hospital also to set aside enough staff to do it. So I also brought you two short examples of the next slide of the actual reduction measures. Next slide. So one thing we did at Heidelberg University is to reduce emissions by bringing a more plant-based food supply. And here you can see just a few results of a 3-month intervention in one of our cafeterias, where we were able to reduce the food-based emissions by 2.5 tons. And that was only in one cafeteria for 3 months. And we reduced the emissions, by about 6 tons. Although that's the blue bars, although there were actually more meals eaten during that intervention period in 2023 compared to the comparative period in 2022. And we have, next please. We have modeled how much tons of CO2 we could actually reduce if we would do this for the whole hospital, so all cafeterias for employees plus all food supply for patients. And we saw that we could actually save 500 to 900 tons of CO2 per year if we would replace one of the 3 meat-based menu lines with a vegan one. So not saying that there's only vegan, but 1 vegan, 1 vegetarian, and 1 meat-based menu line. Next slide. So here, compared to our balance, you can see that the food supply is only 3%. So next, if we want to capture the bigger part, and I combined medical products and pharmaceuticals here, that would be about 37%. Of course, we do need other measures. Next, please. And there are a few examples. So we try to decentivize metered dose inhaler use. We try to recycle some noble metals, for example, in cardiac catheters, together with a recycling company. We try to switch back to reusable instruments because the trend has been to go to single-use instruments. And of course, we want to focus on the general recycling of waste. So just click through the few symbols coming up, please. Yeah, just click through. Exactly. And then comes the next slide. So the lessons we've learned is on facility level, we definitely need that high-level support. We do need engaged individuals, and we need to have a culture which actually enables sustainability. And there it's also important that healthcare staff is already overloaded with work. So we do need a systematic change there. And on system level, we actually need a transformation of the healthcare supply industry. They need to decarbonize, and they need to go into the circular economy model. And we also need legal standards which help to foster that change. Thank you.
I don't think we could see you, but maybe in the discussion we'll be able to see you at some point. But we can hear you very well, so thanks for presenting this. I think our next speaker is also going to be online, but here I hand over to Max.
Yes, we will now continue with a roadmap for conducting the ecological transition of the Swiss healthcare system by Professor Nicolas Senn, who is the head of the Department of Family Medicine UNISANTE at the University of Lausanne and president of the Consortium for the Ecological Transition of the Swiss Healthcare System. Nicolas, we now grant the floor to you.
I hope you can hear me well. Yeah, thank you very much to let me present in a few words this work we have done with the Swiss Academy of Medical Sciences in Switzerland. Next slide, please. Maybe just a brief overview about Switzerland. Just for the Swiss healthcare context, in Switzerland we are about 6 million inhabitants, a very expensive healthcare system with about 90 billion euro per year. It's approximately 12% of the GDP. And the context is very specific in Switzerland with universal coverage, with non-profit private insurance companies, but in fact we have a very liberal, unregulated, market-driven services, especially for the ambulatory sector. The health system is also very fragmented, with 26 cantons, and almost every canton is its own governance. And as a consequence of that, we have also a high impact on the environment. We estimated 5 to 6% the total amount of CO2 emissions for the system. So just a complementary remark in terms of how we thought about this roadmap, and the idea was to go beyond the greening of the supply chains. Even though it's very important, we were thinking about also the governance itself of the health systems and the financing mechanism of the systems, but also to think about a different approach to health and to think about different model of care. So we are really taking the system as a whole and not only one part of it, like the hospital, but also it's great. We will see a lot of challenges. Next slide, please. So that's the roadmap. For now, it's only in French and German. So it's called for Sustainable Healthcare Services Within Planetary Boundaries. And as I said, we took a threefold observation, which is not only the impact of the healthcare services on the environment, but also the crisis and maybe also the limited resilience of the system, even without the climate change, in terms of human resources, financing, etc., and of course the impact of the environment degradations on health. So to conduct this work, we have gathered about 60 national and international experts along 4 workshops in the last 2 years to come up with this roadmap. And if we switch to the next slide, I can really briefly show you how we proceed. So the reflection before to conduct the workshop, we say, okay, we can have different level. We have the very global level with general concept like planetary health, and that's very broad, and I think the literature is already quite rich. On the other side, we have operational measures who are starting to grow up on the ground. And a bit in between, we were feeling that we need, and maybe we can just switch one slide more so we can highlight the middle part, which is the strategic vision of the Swiss healthcare system. So we were interested to work at this level, so quite broad, so we don't lose the big picture of the challenges due to the environmental crisis, but not too specific, not too broad, so people can recognize themselves with that. Next slide, or next part of the slide, and also to define the proposals that we made, or the kind of actions we were proposing the experts to think at 3 different levels. First, to reduce the demand on healthcare, and that's a huge challenge because it's not just continuing to do the same thing, but to have a reflection on all the unnecessary services that we might provide sometimes, but also to adapt the healthcare practices and of course to improve the environmental efficiency, which is important, and that you can have at different levels: the society, the health system, the clinical care, and the infrastructure. So because we had experts from different fields, we could use this framework or this matricial approach for the reflections. So next slide. Here you see in very brief the 7 proposals that came up from the different workshops and which are on the roadmap. The first 3 are related to the reduction of the demand for services, and we'll see that there is an important need to bring the citizen with us. That's the first proposal. So to bring them with us, so we need to be to involve not only the patients but really all the citizenships. The second proposal, it's also to rethink what is the definition of health, because the definition of health might also influence the way we organize the health system. The third proposal is related to reducing the demand on technical aspect of medicine, what we call biomedicine, and to reinforce the social aspect of health, so the social determinant of health. So that's the first three proposals. And the next two are really trying to figure out how we can change the healthcare practices. The first one, the proposal 4, is to develop a new paradigm for sustainable medicine and care. That's to think about new model of care, trying to reinforce primary care, for example, prevention, public health activities. And the fifth proposal is really the content of care to promote alternative approach to care and take into account the environmental issues in clinical practice. We think, of course, at co-benefit approaches in clinical practices. And the sixth proposal, that's where we found most of the existing interventions. It's, of course, to promote the sustainability efforts in healthcare institutions. That's decarbonization of hospital, for example. And the seventh proposal that was already mentioned previously, it's the importance to reinforce the awareness of healthcare professionals in universities, but also in hospitals. So that's very briefly summarized the 7 proposals. So what is coming next? The next 4 slides is just to illustrate with a few examples what is coming next after this roadmap, because writing up this roadmap doesn't make any change to the health system. So the first thing we made is a national forum. Oh, I can just don't see my slide anymore. I think there is something in front of the slide. If you could remove the folders. Okay, thank you. So the first thing that we have done in June this year is to gather all the actors that were willing to come, but more importantly, the health actors who were already doing something in their field. And we were surprised to see that spontaneously we identified more than 45 actions that are undertaken, or at a very small scale in a region or in a healthcare facility, or at a very large scale. For example, at the governance level, there is an initiative trying to change the law really to make the health system more sustainable. So there is a profound change that is behind this initiative. So the first action was really to put the people together and to network the different initiatives. Next slide, please. The second action that we took is also to ask along a citizen assembly health actors what is the most important action that needs to be performed at the national level. And that's just a few examples that came up, but I think from far the most important ones were the 2 first. That means we really need to reinforce education and training of healthcare professionals, what is slowly starting, but we probably have to do much more on that. And the second one, which is the legal and the policy support for sustainable health system. And that brings me to the next slide, which is the third example I would like to show. Exactly by taking the recommendation of the group, we have created this year a consortium. Because we are in a very fragmented country, we can't expect to have one single institution who can organize the sustainability transformation of the healthcare system. So we have created this national consortium. It's led also by the Swiss Academy of Medical Sciences, and it's in line of the roadmap. And we were quite surprised because we didn't proactively ask association to join the consortium, but up to now we have almost 15 national associations from very different fields. We have nursing and medical association, medical faculties, all of them, university hospitals, also all of them, Swiss Ethics, which is the national association of the ethical committee, and we were surprised also to see that the Federal Office of Public Health has joined the consortium, as well as a few NGOs. So the idea is to bring these people together. Now we have regular meetings, we have subgroup of work, and we are developing, for example, recommendation for the clinical care setting. But I think the second proposal is the most important, because now we are initiating a political dialogue at the national level at the parliament and also with the government. We already had interaction with the government in regards of the roadmap and how we could now move forward using the roadmap as a navigation tool for the healthcare system. And of course, we going on gathering all the people together. And the next and last slide, it's maybe to come back on the ground, and that's follow well on what Alina presented. But that's another part. That's the part of primary care, and that's a tool we developed in the western part of Switzerland. It's a website. It's based on the work we have done on the carbon footprint of primary care practices or general practices. That's what you see on the right. You see huge differences in the carbon footprints between the different practices. That was a bottom-up approach to carbon footprint calculation. And based on that, we developed an online tool, what you see on the left, which is the EcoDoc, and all the primary care infrastructure can go on a website, register, do their own CO2 calculation, and the calculator is also providing adapted mitigation recommendations adapted to the context, to what they feel in terms of mobility, in terms of clinical practice, etc. And now it's available, so we are starting to diffuse it, and of course, we are doing a research project based on that. We have almost 150 practices who have already filled this calculation. And the idea is really to diffuse it at the national level, and also to make the part of primary care important in terms of reducing the carbon footprint. So that was a very short overview. I think that was the last slide. And yeah, thank you very much.
Thank you very much.
Just a conclusion. Yeah, that was just the conclusion remarks, but everything was said. The importance of the framework, the importance of the commitment of the healthcare professionals, the idea of the consortium, and of course to have adapted tool on the ground. So sorry for the mismatch.
Thank you very much, Nicolas, for this insightful presentation. And we will continue with Annelies Depoux, Charlotte Halpern, who made this event possible, and with input from Matthias Brun and Laurie Marrauld, our colleagues from Sciences Po and Université de Paris. And you will be talking about decarbonizing the healthcare system, key challenges for public policies.
Yeah, and thank you, Max. And I think what we wanted to do in this presentation was really to focus on the case of France. We're not in England, so we don't have a strong national administration developing a roadmap and telling regions and hospitals, what they should do in order to decarbonize. And we don't have a bottom-up system, as Nicolas just explained, as they do have in Switzerland. We're a little bit in the middle, and what we've been trying to do together with our group has been to accompany the changes taking place in the French system. So in the French health system, basically the challenge is there is increased pressure on the health system. There is also increased needs for material resources and energy. And if we think about an optimistic and still a realistic scenario, we know that we can reduce some 67% of carbon emissions by 2050, but we also know this is not enough. And over the past few years, there has been a sort of a momentum growing. Part of it was launched by a large think tank, the Think and Do tank, called the SHIFT Project, with our colleague Laurie Marrauld, who produced the first sort of assessment of carbon emissions in the health sector. And as part of this, they identified that the largest challenge in the French context is that most of the carbon emissions do not come from one particular producer, so a hospital or elderly care buildings or facilities for younger people or disabled people, but they really do come from treatments. So it's really transversal to all the care system. And so we wanted to take this challenge into account and focus on how we can develop this further from a public policy perspectives and address some of the blind spots that have been introduced, also in the context of a new policy being introduced by the French government earlier this summer. So how did we start working? And part of our first action was really to start from scratch, to bring around the table practitioners, researchers who were interested in building linkages between health and climate policy communities. We did this in two different ways. First, we supported building ownership and leadership by raising the profile of interest to deliver on major policy objectives, and this was done by inviting a number of practitioners at Sciences Po and to bring them around the table and to discuss some of the challenges they were meeting. And we also tried to improve coordination between different organizations, not just between the public and the private sector, but also across levels of government. And it was a very a sort of an innovative approach to also bring local communities and local authorities in the process. And I'll come back to this in a moment. But basically what we identified was that we needed to create a policy community or sort of forum within which we would be talking about such challenges and about 3 specific challenges in public policies more specifically. One has to do with how to develop improved methods and analytics in order to build this link between health and climate. And for the moment, it is not at all built in the French context. We have lots of things in the literature, very interesting things happening outside the country, but this is something we still need to work on. Second, we also needed to think about how to support transformative change in the health sector by working across different organizations, but also taking into account the fact that the French state on its own won't be able to achieve much. It needs to coordinate with what is taking place at the regional and the city level. And this is not something that is particularly strong at the moment in terms of acknowledging what the challenges are. And finally, we also acknowledge the fact that there needed to be some strategic, but also some operational tools needed. And in this context, we very much liaised together with Nicolas Senn, but also colleagues from Heidelberg who have developed such things. Also, the hospital is very interesting for us to be working with them in this context.
Yes. As the low-hanging fruits are being harvested in the infrastructure, buildings, waste, procurement, canteens, etc., decision makers start reflecting on assessing climate-smart treatment options. And as Charlotte just mentioned, the use of medications accounts for a staggering 51% of the total greenhouse gas emissions within the healthcare sector in France, ahead of emissions from medical devices and even transport. Beyond the big picture, this highlights the importance of developing comprehensive multidimensional methodologies for integrating carbon footprint considerations into healthcare decision models. To shed more light on this issue, let me present a study conducted by Matthias Brunn, a psychiatrist and political scientist at LIEP, along with models created by Kevin Zarka and Guillaume Molinier. Their research focuses on depression treatment, aiming to create and evaluate a decision-making tool that not only considers carbon emissions, but also clinical benefits and economic costs associated with depression care. To achieve this ambitious goal, they have chosen to build and adapt a Markov decision model, a tool for evaluating the impact of various healthcare interventions. These evaluations are pivotal in determining the reimbursement and pricing of treatments, providing insights into the long-term beyond the typical short-term randomized control trials. The model developed for the studies simulates the comprehensive effects of 3 depression treatment options over a 5-year period. Pharmacotherapy, specifically escitalopram 10 milligram per day, psychotherapy, and a combination of both. It assesses not only the clinical and economic impacts, but also the environmental consequences, quantifying CO2 emission in economic terms by utilizing the social cost of CO2. The model analysis is informed by data derived from life cycle assessment. What's truly intriguing about study is that it reveals insights that often go unnoticed. The bottom-up analysis for a specific disease, like depression, may yield results that differ significantly from top-down assessments of the carbon footprint at the national level. The latter typically categorize emissions by sectors or functions, while this study dive deeper into the specifics. For example, when examining the economic factor, escitalopram registers at approximately 120 grams CO2 per euro, excluding patient transportation. This stands in stark contrast to the broader figures of 500 grams CO2 per euro reported by ADEME and SHIFT for all medications combined. These disparities raise crucial questions about our priorities in decarbonizing the healthcare system and the need for accurate tools and expertise in shaping a sustainable healthcare future. This endeavor requires significant resources. It represents 2 weeks for the life cycle assessment and approximately 300 hours for modeling and data collection. By far, modeling depression was the most challenging aspect. However, it highlights the substantial impact of methodological choices. Intersectoral considerations are crucial, emphasizing the co-benefits such as the positive effects of active transportation on mental health. There is a notable absence of long-term clinical studies in this area.
So the example that Alice presented is just one of the ways that we're addressing the first challenge that I mentioned about data and analytics. And there's a third one that we're trying to work on, which has to do with enhancing capacities at city level and metro level. This whole idea of bringing city authorities in the loop was developed as part of a pilot project that I led together with the City of Greater Manchester and colleagues from UCL, Professor Peter Jones, the Centre for Transport Studies. And we worked during 3 years in order to support the development of an integrated care partnership in Greater Manchester that would take a broad view on carbon footprint, not just scope 1, 2, 3, but also consider travel demand through the health sector in order to develop some specific actions in this particular context. And building on this idea of what had been achieved in Greater Manchester, we decided to start working and to approach the city of Paris. And this is something that we've been doing over the past 2 years together with Annelies and with Matthias Brunn. We've been working with the city of Paris and the Agency for Greater Paris Area to bridge the gap between the health and the climate policy communities. And we've been working in 2 different directions. The first direction has to do with how to provide an in-depth review of existing efforts that are being led by the cities. We want to document the fact that cities are actually working on this area, even though they still don't have official powers to do so. And the city of Paris is already leading a number of initiatives in the fields of health. There were some 3 studies that were published earlier this year by the Greater Paris agency, offering some very specific information and expertise on how social-spatial inequalities in the field of health has been developing throughout the region, and also trying to highlight what could be decarbonizing initiatives that could be led from the city itself in complement to what the regional and the national authorities are being doing. But we also wanted to highlight through the focus on city level that there also is a number of initiatives that could be done at that particular level in order to increase the resilience of local communities. And this is something that the city of Paris has been developing in the context of preparing for the Olympic Games. This is very, very far away from health. However, they have learned quite a number of lessons from that particular exercise, and they're now developing it further in the context of the climate plan. And more specifically, they have been introducing this exercise called Paris with 50 degrees, in which they have been testing and experimenting with civil society, with residents, with a number of stakeholders at the city level in order to enhance the resilience of local communities, and through this to highlight the powers but also the contributions they could have to discussions taking place at the national level. So to conclude, we strongly believe that bringing together enhanced knowledge and expertise about climate and health linkages is also to do with public policy itself and how to bring stakeholders across different sectors and across the public and the private sector together working on this particular issue. We also have brought together some interdisciplinary research and practice, but we also, we're a university, so we also link with our students and we also connect with teaching activities. Second conclusion is that we now strongly need to develop improved methodology and an integrated approach, maybe something that would be in the format of what has been achieved in the Swiss context or in the British context, but we need to find a way to bring these initiatives together under a single framework, and this is what we have submitted a few months ago in order to get certifying support from national authorities, and finally to develop some tools and guidelines to address organizational, institutional and political challenges, because in the French context these are particularly strong in order to understand what levers could be achieved in order to make progress on this particular issue. Thank you very much.
Thank you. Thank you so much, Charlotte and Annelies. This concludes our presentations, and we now have around 17 minutes for some questions from the audience and also from those joining us online. Thank you to all of the speakers for your really insightful presentations. If you have a question, just raise your hand and we will come with a microphone to make sure that we can hear you. Please also tell us who you address with your question, if it's to everyone or specific speakers, and if you could just give us a short introduction. Thanks.
Thank you, all the impressive work. I work in the hospital. I'm also in charge of the Green Hospital program in our hospital. So I make some kind of challenges. I think that I need your opinion about this. We are talking about adaptation and mitigation, right? And then the first one is that you said that the anesthesia gas desophylline has been banned or reduced, but how do you use that? Like propofol, you use other anesthesia method for the operation? Because I can see that there is a huge difference with the desophylline. So we are trying to reduce the desophylline, but I don't know how to, sevoflurane, aspirin, and but the other anesthesia gas, what do you use? And then, may I ask the first question? Okay, thank you. And then, it is quite difficult for calculate the scope 3. There's some methodology because I'm also a member of GACCH. There is climate impact checkup tool. So we have been holding this kind of workshop. But actually, different country has different kind of, from the LCA perspectives, because it is, the carbon footprint of the supply chain is not that easy to calculate. I don't know, the database you used has been verified, or there is some universal standards for calculating the scopes, such as transportation, food, whatsoever. There's so many things that I don't know how to calculate. The third one is that for medical curriculum, I don't know, because the medical curriculum is so compact. So it is very difficult for me to persuade the university to integrate the curriculum of climate change into their, I don't know, how do you have any strategy to try to persuade the clinical and also the basic medical science teacher to adopt the curriculum for climate change? Thank you.
Thank you so much. Those were many questions. We will start with the ones that you raised regarding anesthesia and especially desflurane and alternatives to desflurane, but also alternative methods for narcosis. Alina or Rainer, you want to start, and then
Alina or Noemi, you can come in and explain what with what we substitute the fluorine anesthetic gases. And then I think, Bernd, you can explain the question or respond to the question of the calculator. and Alina on the education. How do we squeeze in the additional content into the compact medical curriculum? So who was first? Noemi. Noemi, or Alina on the gases for anesthesia. Noemi. Yeah, go ahead, Noemi. We don't hear you.
Anesthetic gases, can you?
Yeah.
Ah, yeah, right. So the anesthetic gases, they completely stopped using desflurane, and they shifted to sevoflurane and isoflurane, but not in the same amount. So they reduced the flow rates during anesthesia.
Wow.
Does that answer your question? If you need more details, you can also contact me, of course.
Yeah, yeah. Alina, can you add something?
Yeah, I can,
Substitute.
if you hear me.
Yes.
Yeah, okay, so yeah, it's just as Noemi said, and there are different techniques to lower the use of the remaining gases with low flow anesthesia, or also using total intravenous anesthesia, for example, with propofol. I will continue talking about the teaching aspect. So we have submitted a proposal to the medical faculty where we said we will not introduce new courses or new modules, but that we will actually talk to the managers of the existing teaching modules individually and ask them where we can introduce planetary health aspects within one existing lecture or an existing program. Maybe one example, we also have this problem-oriented learning where medical students work on a case study of a patient, and it might be a case study on heart attack, and then we can add something that the heart attack has been happening in a heat wave. And while we already have 5 or 6 questions about heart attacks and the physiology and therapy, we can also ask one question or one aspect about the elevated risk in heat waves, or what we can do in order to adapt to high temperatures in the healthcare system. So that's the kind of approach we longitudinally integrated into existing areas. One more example for sustainability aspects. So we have talked to our nephrologists, and they have said that they would be interested to introduce something on the carbon footprint of dialysis. So now we are working with them in the dialysis lecture to also integrate a few slides on the carbon footprint of dialysis and how to reduce it. So that's how we go about the teaching. And now over to Bernd, if you're online. The question, as I have understood, was how about the validation of our carbon footprint calculation tool?
That's a very good question. Thank you for that. We indeed have to find a balance between accuracy and usability in performing a greenhouse gas calculator. For that reason, we try to harmonize our approach. For example, with Healthcare Without Harm, they have a greenhouse gas calculator, and we cannot do bottom-up LCA emission factors for the millions of medical products and the hundreds of thousands of pharmaceuticals. So we use input-output table derived emission factors that are giving you a number in terms of tons of CO2 per $1 million or million euros. However, when we do work to trigger an action, and that is the prime reason for the calculator, to show that yes, there is a large contribution from medical products and pharmaceuticals, then we can, in terms of monitoring a specific intervention, go more into depth. So I don't think it's really helpful for everybody. but this is how we do it. And if you want to work with us to harmonize and to exchange ideas, we can progress much faster on this.
Nicolas, you want to add something? It could be a short answer so we have time to take more questions from the public, because there are more questions here, so we want to make sure that we get time to gather that. So.
Yeah, maybe just a quick comment on the teaching aspect, because we have implemented about 2 credits curriculum in Lausanne. And I think one very powerful mean to implement that was to have the students with us. And the students were pushing quite hard. And I think that was a good lever to go to the faculty with the students. So I think that's a good trick. If we don't have a faculty who is very in favor of that, I think going with the students is good.
Great. Thank you so much. Really, really great presentation. And so my name is Julien Pouy. I work for United. We're a WHO-hosted partnership. We happen to be a partner of the CAA as well. So I'll ask 2 questions, maybe 1 question for Trish. The project you guys have been doing, starting to do, I guess, still in progress in Chad. I have 1 thought-provoking question. I guess as part of the vulnerability assessment you've been doing, I'd be very keen to hear back from you as to whether you've identified any particular product, health product, essential products, basically, that are not future-proofed. And I mean by future-proof, I really mean climate-proofed. Products that we foresee might be difficult to handle with low energy or dependencies on energy access, products that are not heat-stable, or product that may be facing humidity resistance. So really, as part of that sort of a pilot project, is there any particular life-saving product that you've identified? And building on that particular question, there's really kind of a product question. We're a product-driven organization. That's why eventually I'm trying to nail things down here. Maybe a question for you guys. We've been working with the SHIFT project. We've been discussing with Laurie and our team a couple of weeks ago as we were in process of doing a life cycle analysis of 10 health products. I'd like to hear back from you as to what your current thought process in terms of using the life cycle analysis the best way possible, be it as part of the procurement process, as part of a broader graduation process. I think at some point we all need to be that skilled with doing a product life cycle analysis, or at least be able to put some carbon glasses in front of us anytime we try to think about product, especially in the healthcare system. Over.
Great, thanks.
Maybe
Thanks.
Trish, is there another question so we can collect? No frustration on this side of the room? Okay, Trish, sorry.
Yeah,
Please
no, that's
go.
okay. Yeah, that's a good question. I can look into the solution matrix to see if there's particular products, because nothing really springs to mind at the moment, but there were 65 solutions. And I know, like, from the team in Chad, one of their biggest priorities was strengthening the blood bank so that they could deal with peaks of malaria. And the cooling solutions around the cool roof, passive cooling, and solar air conditioning was with regard to cooling the ICU so the clinical temperature could come down, but also the pharmacy. So I'm sure there's products in the pharmacy and the storage area that could be vulnerable to heat. But yeah, I can give you my details later and we can look into that in more detail.
Thank you. And the second question, I believe, was for you.
Yeah. I'll take the second question, even though I'm not representing the SHIFT project and Laurie isn't here, so I don't want to speak on her behalf, especially not because they haven't made a decision yet on that. So I'm going to politely shift the ball back, but I guess one of the things that we identified when we were working, as part of those workshops with practitioners and researchers, that we definitely need to have more insights on how those tools, what are their impacts, what are the long-term impacts, and how will they have an impact, not just on carbon emissions reductions, but also on reorganizing the way through which the health system functions. So we're talking here about relationships between public and private sector, regulatory capacities and how this could be strengthened on the public side, but we're also looking at how this should or will have an impact also on the ability of different professions. Could be, we can talk about chemists, we could talk about hospitals, we could talk about doctors, and how this and the use of a particular tool such as life cycle analysis will have an impact on the measurement of carbon emissions, and through this on reorganizing those relations. And I think this is the kind of feedback, the kind of approach that we still need to have. We don't have this reflexivity yet, so this is maybe a very much of a researcher's position here speaking, but a lot of those tools are just happening at the moment, just being brought onto the market, and there is a need sort of look at this, use them, experiment, innovate, but also to test and evaluate and decide, you know, how and whether or not it will also contribute to achieving the broader and the wider impacts that the health system is also trying to achieve beyond this climate changes one, but also the just transition aspect, as well as reducing social-spatial inequalities. And as we saw from the case of Paris, this is something which is still quite important in a number of territories in the French context at least. So, yeah.
Can I come in? We
yeah,
are,
1 minute. Yeah.
We are talking a lot about measurement, about education, but something that got a little bit lost on the way was the social engineering. How do you bring change into a very conservative population like a hospital? And I would like to ask Claudia. Claudia did a wonderful PhD work on stakeholder analysis. She talked to all stakeholders from the porter to the director. What do you think is the biggest problem here, and how can we solve it? So, Claudia, can you give us a little glimpse of what you did and how important it is to do what you did?
Yeah, thank you, Rainer. I hope you can hear me. I think if it would be really easy, then I would have a good answer to your question. But I think one very important point is that people working in hospitals often fear that doing things environmentally friendly threatens patients' health. So I think this is a really important point to address. On the one hand, to find ways how we can reduce emissions while still keeping up a very good quality of healthcare. And on the other hand, communicating these insights to the healthcare professionals so that they know they can still treat their patients well. I think this is a really important point to address, because even in the hospital, people start thinking about environment, especially waste was often addressed by healthcare professionals because they see the great amount of waste they produce every day and want to change something, but don't know how and fear this conflict. To keep it short, I think this is one of the main points.
Excellent. Thank you, Claudia. Looking at the time, thank you everyone for your participation, for your great questions. Thank you to the UNFCCC for granting us the opportunity to host this side event. Thank you to all of the speakers and our great partners to make this possible. I think we've learned a lot today, especially when it comes to what drives change and what does it require to make the transformation work so that the health system plays its role both in mitigation but also builds resilience so that we can provide for the future, a future on this planet that is worth living on. Thank you all so much for your participation. Would you like to add anything? Thank you. Hopefully see you soon.